Assalamu alaikum doctors. In this video I am discussing a recall communication that come recent Jeddah 2024 that is about tracheoesophageal fistula. So tracheoesophageal fistula, as usual we are starting with IRCAP. So he is having a condition called tracheoesophageal fistula. Have you heard about it before? No doctor. Let me explain for you, but please follow me at this drawing to make myself clear. So we'll draw like this stomach food pipe, that is esophagus, and the trachea, and there is a connection between. We'll show that. So we draw this normally from this part of our neck downward, pointing to your neck. There are two tubes, the air pipe and the food tube. The air pipe transferred the air from our nose to the lungs. The food tube transferred the food from our mouth to the stomach. Are you with me? So first we explain the normal. That from our neck pointing to the neck there are two pipe go. One is food pipe, another is air pipe. What happen in air pipe? We take the air from the nose to the lungs, and food pipe we are taking food by orally and it go to the stomach. And normally there is no connection between these two tubes. But in Ali's conditions, the food tube is divided into two parts. The upper part ends blinds making a pouch and the lower part connected to the air pipe. Am I clear? So there is a connection between these two tubes. Okay. In other hand, we need to do further test. We need to examine his backbone by X-ray to backbone and the jelly scan of his heart to exclude what is called Vateral associations. So Vateral association, VACETREL. That is, we know that it is one of the syndrome. Normally, tracheoesophageal fistula associated with the syndrome. So confirmation we need to do backbone X-ray of the backbone and also jelly scan on his heart. So mother is asking, what is the treatment? Surgery. He will need corrective surgery. He may need to be attached to breathing machine for a while and after having this surgery. Okay, after a while. Okay. So what is the treatment of tracheoesophageal fistula? Remember, it is surgery. Is he gonna die? Let us hope for the best. Most of the children with this condition, even they needed surgery, they can live normal life, even it takes some times. So this is we tell. Tracheoesophageal fistula is mother is telling, or if with the medical student, what are the symptoms I am telling? Polyhydramnios, excessive salivations, respiratory distress, abdominal distension, there is choking of food, inability to pass the NG tube. These are the features of tracheoesophageal fistula. This is polyhydramnios history. Mother has much fluid. Then excessive salivations, respiratory distress, abdominal distension, choking after feeding, inability to pass the NG tube. So inability to pass the NG tube is clinically we diagnose. What caused this? May suggest possible genetic cause and teratogenic influence. So genetic and teratogenic influence. If family history, so increase the risk. Is he need admission? We need to know that if the condition is isolated or in association with some cases as Vectoral and vectoral full I am telling. V for vertebral any problem, A for anorectal problem, C for cardiac problem, T for tracheoesophageal fistula, R for renal problem, and L for limb abnormality or chromosomal abnormality. Trisomy 13, 18, 21. So we have to do the jelly scan of heart and blood test for chromosomes. Treatment is surgery needed. I already tell, that is right lateral thoracotomy, urgent or delayed H-shaped side of the chest as according to the birth weight and other associations. We involve the multidisciplinary team, that is surgery, chest physiotherapy, respiratory physiotherapy, dietitian and speech therapy. How can we confirm the condition if they ask? First of all, by passing the NG tube. It will curl and confirm by chest X-ray. So NG tube will not go to the tummy because it will be curled. And we confirm it by X-ray. Imaging renal tract we can do, ultrasound jelly scan of the spine, then X-ray of the back, jelly scan of the heart. In X-ray of the back, gapogram may be necessary to assess the distance between the proximal and distal part of the esophagus. And complication of the surgery, if mother is asking, that is leakage of the anastomosis, recurrent tracheoesophageal fistula, sometimes it recurrent occurs, stricture, feeding problem, poor weight gain, gastroesophageal reflux disease, and recurrent chest infection. So this is all about the tracheoesophageal fistula communication. Thank you.